Welcome to Health System CIO's interview with Dr. Carla Haack, VP, Chief Financial Informatics Officer, and Assistant Professor of General and GI Surgery with Emory Healthcare. I'm Anthony Guerra, founder and editor-in-chief. Dr. Haack, thanks for joining me.
Thank you for having me, Anthony. It's a pleasure.
All right, this is exciting. I'm excited. I have not, in my years, and I'm not a young man anymore, I have not interviewed a chief financial informatics officer. So I'm very excited, and I suspect this may be a trend in terms of this position, but looking forward to chatting with you about it. So if you want to start off, tell me a little bit about your organization and your role.
Well, thank you for the invite, and you would be correct. This does appear to be a trend. I first came to Emory in 2005 as a visiting medical student, and I fell in love with the community and the people there, and was really honored to be invited back as a general surgery resident, and even more so to be invited to join the faculty when I finished my training. We are a major academic health system in the Southeast US. We currently are 11 hospitals strong and counting, uh, with a huge associated network of outpatient clinics and providing care in all sorts of specialties. I am fortunate to have enjoyed a really robust clinical experience, and to have worked with some of the most brilliant minds and compassionate hearts in healthcare, and in higher ed, to be clear, because we are also a higher ed organization.
Mhm.
And after the pandemic, healthcare organizations took a hit. And so was looking for ways to make myself useful, and hearing that financially we were in a situation that we had never been in before, and hearing that we needed to be more productive clinically, and feeling a level of cognitive dissonance because my partners and I and my clinical colleagues and I felt like we were really busy and like we
Mhm.
were doing a lot of work. And started investigating that disconnect and trying to really understand how it is that we could feel so busy, and yet the budget could be so bad, even acknowledging the difficulties that healthcare faced in the setting of COVID. And that's kind of when I realized that we were deeply siloed and to our own detriment, because the clinical teams didn't really communicate well with the revenue cycle teams. The revenue cycle teams didn't feel like they could easily communicate with clinical teams because we were always tired and disgruntled and grumpy, and we didn't speak the same language. And as a result, everyone suffered, and
Mhm.
found that there was a lot of opportunity to be a translator for the different groups. And that happened to be at the same time that we were in operationalizing an EMR transition from Cerner to Epic. So really interesting moment in the organization's history when we've just gone through a major pandemic, and we are changing the entirety of our technological platform. That gave me the opportunity to partner with people across the continuum of care and beyond the clinical realm into the revenue cycle space, where um, we could define what an ideal process might look like in a technology agnostic manner by communicating clearly to each other who needed to know what when. And how do we then make it really easy to capture that and put it in the place that it needs to be, so that everybody has a better day and we can have our clinicians have the best experience of caring for our patients. Obviously, that translates into our patients having the best experience, and then making it really easy for the clinical teams to get credit for the work that they've done in service to our community and to our patients. So that may have been more than what you were looking for out of that answer, but that's
No, no.
how I got here.
That works. That works. That explains a little bit about how you got there, but there's some interesting jumps there that I'd like to get into and explore a little bit. So 99 out of 100 physicians, if they heard, hey, revenue's down and, things are tough and those kind of things, they would not say, "Well, let me figure out what's going on here. Let me try and improve the revenue cycle." They'd say, "Yeah, well, that's not my problem, right? I'm a clinician." And I think there's a cultural issue there where a lot of clinicians feel like, as I think you alluded to, that's not my lane, right? I do medicine. You didn't. You said, "Oh, this is interesting. I'm really busy. You're saying revenue's down. I don't see why it should be down. Let me go take a look." So that's really interesting. And I guess that speaks to probably your personality and some of the things you've accomplished in your life. You find a challenge or somebody says something doesn't make sense and you go, "Let me go investigate." Am I right?
Yes, yes, you're probably right. I'm really grateful that I feel like my family and then my surgical training equipped me with a desire to go fix it and just make it
Yeah.
better. If I have the ability to do that. Life also gives you what you need, even if it's not what you want. So
Mhm.
um, contemporaneously, I I had some life events that forced me to go take care of family members that were at the end of life during that moment in time, which and none of them were geographically convenient to my OR in Atlanta. So I had to take a step back from the operating room and go attend to what was happening in my family. That made it so that I was not in the operating room when some of these conversations about the
Mhm.
revenue cycle were happening. I had
Mhm.
foot in the door in
Mhm.
that I had taken on an administrative role in 2015 as the medical director for care coordination for Emory University Hospital, which is our flagship hospital. And that position put me in a place where I was interfacing frequently with payers and doing a lot of the peer-to-peers for the statusing denials when we were trying to decide between inpatient and observation and outpatient for a given patient's case. So I had a little bit of a toe in the water, if you will,
Mhm.
on the
Mhm.
operational and administrative side of things. And that actually felt like a really valuable role because few things are more annoying than being caught up in patient care and to hear that you got to stop what you're doing to go do a peer to peer with an insurance company. And I say that with all due respect to my medical director colleagues on the insurance company side. So I had a little bit of an interest there. And that ultimately is part of what made me raise my hand and say, "Hi, can you invite me to this meeting that would otherwise happen when I was elbow deep in somebody's body cavity trying to do surgery?" So being that I was not in the operating room anymore
Mhm.
and that I had the ability to join some of these meetings that were now happening virtually because this is in the wake of the pandemic, that's when I sort of started getting a little bit further into this space and was kind of shocked to realize the level of opportunity that existed in this space. So that was part of how I ended up here, in terms of it wasn't just that I had a little bit of interest and a little bit of experience, but also that life sort of
Mhm.
made it such that I had the time where I would have never been able to do that if I had been clinically committed the way that was my bread and butter, up
Mhm.
until that point. And it was very eye-opening how a little could go a long way. Just helping folks on the revenue cycle side interpret clinical documentation to understand whether what they were interpreting from the codes that made it to them is what the physician intended when they wrote their note and laid out their thought process. So that was a combination of my training, my indoctrination, my upbringing, and just life events. Um, and then, trying to do the best you can with what you've got. I will say this, which is that I actually think that we do ourselves a huge disservice in clinical training and in clinical practice by allowing ourselves to remain ignorant of the rules of engagement that dictate how the field that we work in operates. So we don't really understand, a lot of us, some of us understand it very well, but at least in my experience, a lot of us didn't really understand, and I will include myself, how does the work that I do translate into revenue? Who pays for that and how? What happens if I get a denial? What happens to my patient if I get a denial? Because I think the other thing that was really urgent for me to address was the realization that if I didn't come up with a plan of care that was covered by my patient's insurance, my patient could end up with a bill. And healthcare costs are the leading cause of bankruptcy in this country. And so I needed to understand how it is that I could do a better job of taking care of my patients in a holistic manner, which includes being a responsible steward of their financial resources, as well as understanding how it is that I could help my clinical colleagues be more effective within the system that we function within, and very much, let me be candid, through the lens of well-being. I'm a yoga practitioner and enthusiast, and I sponsor a yoga program at Emory through the generosity of the Rollins Foundation. And I got the message loud and clear that yoga wasn't enough if the job was still harder to do than it needed to be. And make no mistake, the job is always going to be hard, but it doesn't have to be this hard. And I don't
Mhm.
have to feel like I'm spinning my wheels trying to take care of my patient because I don't understand what the insurance company needs from me. So that just felt like an area that was ripe with opportunity. And those of us that go into clinical care and try to think that we're not fixers are lying to ourselves and everyone else. So being a self-proclaimed fixer, I figured it would be useful to get into that space and try to make myself useful.
Yeah, so the "it's not my problem," sort of feeling that I've gotten from my physicians in the past regarding the paying side, regarding that whole element of it, um, sometimes they say, you have to see the office manager or you have to see someone else, basically, I don't know, and essentially, I don't care. That's not my deal. That's tough because as you said, the insurance may not pay for the plan, and then you mentioned bankruptcy, but it's just as possible that the patient opts not to get the care you recommended because it's not covered in whatever, and that's that. So, yeah, you prescribed this or you said, "Go, I should do this," but they're not paying, and I can't do it. So you're right, it is important, but, you mentioned medical school, maybe it should start there. That's gotta be a long-term culture change on the clinical side, right?
Think so. I
Yeah.
think so. And I think that I was one of these people who was so it's overwhelming when you're in that role of trying to take care of people and deliver the care and do the surgery and talk
Mm,
to the patient and the family. And it feels like, oh my gosh, somebody help me with part of this, right? At least
right,
somebody help me with the counting of beans.
right.
So I completely understand how it is that it feels like I no, I really can't take that on and I really do need help, which is part of
Yeah.
why I think that ultimately I made the decision to pursue figuring out how I could be helpful to my colleagues in this space and ultimately made the decision to continue exploring this space as opposed to go back to the operating room full time like I had been doing previously
Mhm,
because it's not organic. It's not common that we would organically end up working in this space for a variety of different reasons, many of which you already articulated, and the sentiment that you articulated very well. I think the key that I learned is that a little can go a long way.
mhm,
Having a basic functional understanding of how this works actually saves you time and effort. And having a clinician colleague potentially pre-digest some of that for you to say, look, this is what your note would say if it was going to be really helpful for you, then let me think through how I can make it really easy for you to capture the verbiage that you need to capture in the process of delivering patient care so that you can capture the words that you need for the insurance company to understand what it is that you're trying to do in a way that doesn't add time or clicks or steps to your already loaded workflow and busy day. And then let me make sure that I'm helping the people that aren't clinical understand what it is that you're trying to say when you use these words so that we can just all get on the same page.
mhm, mhm,
So I think there's definitely a change that is needed in terms of how we train, but I don't think that every single one of us needs to get an MBA or get titles that have finance in them. I think it's really more of helping people understand how it is that they can function within the system and giving them that working knowledge just to make it less frustrating and less inefficient and less painful for all parties involved.
Right. Excellent. So, from as you were talking, what I'm thinking is you attack this problem on multiple fronts. And one which you mentioned would be attacking it on the clinical side, speaking with the clinicians, giving them some basic education and pointers you mentioned a little bit goes a long way. So, and I'm sure AI is going to come into play with that, where not only is it doing the ambient listening and helping to create the note, but that note can also, you can also ask it, I'm sure already probably, to optimize that note for coding purposes or whatever the proper terminology be. So there's the clinical side of improving the note, which really dovetails with the knowledge of what the payers want, right? So we have to know what do the payers want, and then we can do two things. Once we know what the payers want, and maybe and they're all different, probably all the payers want different things. Um, so they want different things. Then we have to bring that knowledge to both the clinical side and the revenue cycle side in our organization, throw in some AI, and we can do a lot of improvement. We can really increase revenue. Does that make sense?
It absolutely makes sense. And I want to be careful about this concept of just increasing revenue, because I think the part that really gets me out of bed in the morning is just giving people credit for the work they've already done. And increasing revenue is a side effect thereof. But for me, it's not so much about how can I squeeze every dollar out of this for my bank account sake. It's really how can I make this work that people do with so much passion and sacrifice and commitment and dedication actually be fairly recognized by the organization and for the organization. So, and
Yeah.
yes, increasing revenue is a side effect thereof, but it's more about making sure that credit is given where credit
Yeah.
is due.
And I think that's what I meant. When I said increasing revenue, I meant to the level of where it should be. What
Absolutely.
yeah. Yeah.
Absolutely. And I'm sensitive about it. I'm
Yeah, no.
because I think that one part of what turns clinicians off when you
Mhm.
start talking about the revenue is that it's a means to an end, but the revenue is not why most of us do this. And it's not a powerful motivator for a lot of us. It can actually be, I've found people who kind of glaze over and shut down when you start talking about the revenue aspect of it. And make no mistake, no margin, no mission. So you got to be able to keep the lights on
Yeah.
to do what you're doing. But I have found to be really careful in how I choose my words when I talk about why, because I don't want anybody to think that any of this is intended to just make more money. The revenue side of it is really a side effect of having sound processes and getting credit for an honest day's work. And I just want that to
100%.
be, and I don't think that you misunderstood me
Yeah.
at all, but I
Yeah.
like being really explicit about it
Yeah.
to make sure that I address all of those people who might be like, oh, she's crossed over
Yeah.
to the dark side.
Yeah, and so it's a great point. So I meant what you meant, but your point is very valid, which is words matter. And when you're speaking to someone, you can mean one thing, but if you don't, you have to understand your audience and their sensitivities. And so doing, clarifying afterwards. Number 1, that means that they've taken it the wrong way. So for some period of time, they've been displeased with what you're saying or mentally checked out, right? So even if you try and fix it afterward and say, "No, no, no, that's not what I meant," you don't wanna have to do that. So how do we avoid that whole process is we figure out how to articulate this in the best way for the audience, and that's what you're talking about. So again, what we're doing here, our conversation here, is all for the benefit of folks. Either there aren't many of your positions, but people that are trying to do the work you're doing and to help them. And this is an important lesson for them that words matter. Anything else you want to say on that front?
I think we need more people to do this kind of work.
Yeah.
So I appreciate that question, and I appreciate the way that you received it, because this is a space that isn't necessarily naturally attractive to a lot of people who choose to go into healthcare. But It is a really important service that we can provide to our communities, the patients we serve, the people taking care of them, and the people that are trying to help the people taking care of the patient. Uh, so don't don't for one second think that there's something ignoble about it. On the contrary, please consider it as an important service to your patients and your colleagues and your community, because it's just trying to be knowledgeable and skillful within the system that we function within, and ignoring this has been to our own detriment and to that of those we serve.
Well, I couldn't agree more, and in fact, I would go further, and this is my own opinion. I think it is ignoble not to care about this element of what you do, because not to care shows a disdain for reality. You mentioned at the beginning of the interview the dynamic of working your butt off, so to speak, and being told, we don't have revenue. And what does that mean? When somebody's telling you that we don't have revenue, they're telling you we can't do certain things that you want to do clinically. You may want to do things for your patients or this or that, and they're saying, well, we can't. We don't have the money. Why don't we have the money? Because nobody cares about the money, or at least a lot of clinicians don't care about the money. So that's a problem. That's not noble, not caring about the money and thus having downstream effects that, impede the kind of care you want to deliver. It's all part of the same, the only problem would be if you perceive increased revenue as going to ignoble causes, somebody's bonus or something crazy like that. But if you perceive it the right way of what we can do if we get revenue to where it should be, should be on board. These are smart people. They can understand a few points. If they want to improve the note from a coding point of view, it's probably not that hard, right? As you said, it's a couple of points. I read, you wrote a great article that was posted on the Epic site, which I was very happy to have found. We'll put a link in there to it, um, where you talked about the value of working with these folks and how, there was no ego there for you. You're willing to chase them around. You're willing to follow them, catch them before the OR, catch them after the OR. So I thought that was really interesting. That's really one-on-one, we call at the elbow support, bending over backwards to accommodate these folks who, and you were one of them, who are hard to get a hold of. So, any other thoughts there?
I think that the folks that are on the clinical front lines deserve all the help we can give them.
Mhm.
I think that there's no ill intent in saying I can't take on the financial side of that, or I'm just going to need somebody else to help me with that. There's no ill intent there, because I fully appreciate how it is that there's just not enough time in the day for all of it, and it can sometimes feel really offensive to have somebody ask you to spend time doing something other than spending time face to face with those under your care and
Mhm.
addressing their concerns and giving them the best that you've got. So I think that there's an element there of recognition that healthcare exists because healthcare workers are willing to sacrifice a great deal to provide care to those that are vulnerable and suffering. So a lot of, and having been in that role and feeling that burn and feeling the overwhelming task list and to-do list and feeling chronically like the demand is greater than what I am able to meet is a really hard way to live.
Mhm.
So I am absolutely willing to do whatever is in my power to make this convenient for them, because the more convenient I make this side of things for the people delivering care, the more face time they can spend with their patients and their families, and God forbid, taking care of themselves, going to the bathroom, feeding yourself, and maybe even getting a good night's sleep. So
Mhm.
I think that it's really hard to do both. Clinical care is something that when I'm wearing the white coat, I don't do a good job setting boundaries. And that makes me really good at certain things, but it also comes at a very high personal cost. And there are all around me, part of the reason why I am willing to meet physicians or clinicians or whomever it is that I can help, wherever it is that they are at their convenience, is because I know that how it feels to just feel like there's not enough. The task is overwhelming and you try so very hard to meet it. And
Mhm.
it's a Sisyphean task
Mhm.
sometimes. So I'm really sensitive to that. And I'm sensitive to the fact that a lot of them are saying, help me do this. They're not saying, I don't want to deal with this. I don't
Mhm.
care. They're saying, I have so much, I can't do that. So help me navigate that part of it. And part of what I think gets in the way of that message getting through clearly is that by the time we're having this conversation, who knows when the last time we slept 8 hours was, or what our last meal was, or when the last time our needs were met really was. So when our needs are chronically unmet, our communication suffers, our emotional management suffers, and therefore when I say I can't deal with this, I might just be saying I don't understand it and I need help, but it doesn't
Mhm.
come out that way because I'm
Mhm.
not at my best.
Mhm.
And I don't feel like I have the time to really think through that and communicate it in the way that's most effective and clearest. So having been the person who many times in my career communicated something and then realized afterwards probably could have done better at that, and thinking through what I was feeling when I gave that response that maybe wasn't the most effective one at the time, just made it really easy for me to put myself in those shoes and say, how do I make this work for you? How do I make myself helpful to you? And how can I be of service? And it's been a really interesting journey for me because I practiced as an attending physician at the same organization where I trained. So a lot of my mentors became my partners. And I had to look a lot of those people in the eye when I made the decision to step away from the operating room. And the surgical ego is a mighty thing to wrestle with. I will acknowledge that freely. So there were all of these questions of is this am I a waste because I'm not in the operating room? Was my training wasted on me? Where guilt and shame and the avoidance thereof are really powerful motivators in my life, at least. And I think that's true for a lot of clinicians. And and the response that I've gotten from my mentors, some of the people that were really intimidating to me in training and in practice because they're brilliant surgeons that are
Mhm.
at the top of their field and they
Right.
hold themselves to an incredibly high standard. To have those people look at me and say, no, 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 we need you right where you are. We need you doing what you're doing because what you're doing is so helpful to us and so valuable to us. And we're training residents every day, but there's not enough people doing what you're doing.
Mhm.
Don't stop doing what you're doing. We miss you in the OR, but we'll figure it out. That
Wow.
that kind of feedback
Mhm.
is the most powerful indication to me that I'm on the right track. When
Mhm.
I feel like I can help the people that made me a surgeon and that held me to a really high standard of clinical care, and to have those people say, you're helping me in a space that nobody else is helping me right now.
Mhm.
That's
Mhm.
part of why I would encourage the clinicians out there that have been thinking about this to consider it very seriously because you are providing support in an arena where we're vulnerable.
So we would encourage clinicians to think about this type of role and to consider it and perhaps to pitch it if they feel passionately about it, if it doesn't exist. And we also want to encourage those who may be in this type of role to understand how to engage with clinicians, right? And you mentioned them being highly burdened with their work. We talked about catching them coming in or going out of the OR. So if someone was in charge of this at their health system, and maybe they weren't a clinician, or maybe they didn't do surgery. I'm sure dealing with surgeons is different than dealing with every other kind of doctor, right? I mean, the psychology of clinicians is probably a lot of fun. Um, what would your best advice be on how to engage? Again, let's say your mandate at your health system is we want you to improve revenue cycle. We want you to improve what the revenue cycle team's doing. We want you to improve what the clinicians are doing. We want you to liaise with the payers. We want to improve this whole process. What would your advice be around how best to engage with the clinicians to get them to be receptive? I mean, I'm picturing you trying to approach somebody after they're done with an OR, procedure, and perhaps on occasion saying, "Okay, not today. I get it. I'll come back. We'll try again." Like they're not happening today. Not good to talk to me today. So, any high level thoughts there and advice for those folks that may be in charge of this or may eventually be in charge of this?
I think a spirit of humble inquiry in all directions goes a really long way. I did a lot of humble inquiry when I was learning about revenue cycle processes and finance and business. That's not what I went to school for. Help me understand it. Help me learn about it. Um, Put yourself in someone's shoes. Think about how you might feel if you haven't slept, you haven't eaten, you haven't been able to go to the bathroom, and you have to give somebody really bad news or really difficult news. And every single moment of every single day, you are expected to be able to help people who are having their worst day.
Mhm,
Think about that when you go interact. And also, to my clinical colleagues who may consider in entering this space, think about the fact that the people in the revenue cycle and the people in finance and the people in the budget side of things, they know things that you don't know. They understand things that you don't know. So think about how they might feel if you come in and talk down to them, or
mhm,
sort of have any give any kind of impression that you're better than them. And I'm not saying that physicians do that intentionally. It can come across that way sometimes, because there's all these coping mechanisms that we need to develop to have the confidence to do what it is that we do, and to make some of the interventions that we perform. So figure out how it is that we can collectively try to put ourselves in each other's shoes, and understand that we don't know, none of us knows everything. We need each other. We all absolutely need each other, and we need to help each other out so that we can all have a better day.
mhm. Yeah, for sure, and that's you said the coping mechanisms that we use to do what we need to do, right? I mean, that's it. When you're doing those type of things and someone's on a table and you're doing things to them that they could live or die, that you have to do certain things to be able to live with that when there aren't optimal outcomes and go on and do it again. So that you sometimes what it takes to do that makes you perhaps not always in the moment say things exactly as you like to say.
Correct, correct. And we pay a really high personal cost to
Mm,
get the experience that we need to get in order to do that as a second nature, right? You have to do it over and over and over and over again when you're exhausted, when you're hungry, when you don't feel good, so that
mhm,
you can do it when you're
mhm,
exhausted and when you're hungry and you don't feel good and you're the only one that's there and somebody needs you. And that's just, it's a double-edged sword. It
mhm,
can serve you really well in certain situations when you can be that tough. But sometimes it's not the most useful way to approach a situation, and being able to meet the situation in the most skillful way requires a great deal of personal regulation, which is
mm.
compromised when your needs are chronically unmet.
I love that. Imagine saying that to someone, "I'm sorry I yelled at you, but my needs are being chronically unmet."
I'm writing.
You what? Say that again?
I have to put that in writing, right?
Mhm.
Like, there have
Yeah,
been so many times
a
where
sign.
I haven't responded as well as I would have liked to, and thankfully I've had the opportunity to step back, take a beat, take a breath, do a little yoga, and say, gosh, you know what? I could have done better with that interaction. And I'll say this too, which is that some of the strongest and most resilient relationships I have with people where I had some kind of misunderstanding, or we didn't see eye to eye, and we went through something super awkward and
Mhm,
uncomfortable and
mhm.
painful together. And I think that trust is built on shared vulnerability, but it's really hard to share your vulnerability when you're expected to be able to quote unquote save somebody. Um, showing vulnerability when you're taking somebody to the operating room is threading a needle. It is a really delicate balance because the person trusting you and the people who love that
Yeah,
person
yeah, yeah.
want you to be invulnerable.
Right.
And there's all sorts of dysfunctional ways that that can turn out. And so being able to say, look, I am going to guarantee you 100% of my effort, 1,000% of my
Yeah,
effort.
yeah,
I
yeah.
will give you everything that I have, but I still don't have as much control over this outcome as I would like. And yes, I'm scared. Every time I cut skin, I'm scared, and I should be. The day that I'm not scared when I cut skin is the day that I should never cut skin again. But being able to articulate that
Sure.
in a way that doesn't undermine their confidence in your ability to deliver the highest quality care is threading a needle.
100%. And we can imagine comedy skits where you don't do that and you're like, "Oh, I'm scared to death." Right? That's a comedy skit where you're telling a family that you're scared to death before you're going in the OR. So it's yeah, I mean, I certainly have a lot of respect for clinicians like yourself and those type of folks. Let's talk a little bit about C-suite support or support, you're a C-suite, but I mean, you're gonna get end arounds, I assume. Not everybody's gonna love being approached with this. There can be an instinct of not my problem, not my job. As we said, we want to overcome these things. We can do presentations and education as to why you really shouldn't feel that way and why it's worthwhile to embrace this. I'm gonna imagine on occasion there will be the recalcitrant doctor who, you know, stop coming to me. I'm not dealing with this. So there you have to have support, right, above you, because you're gonna get the end around once in a while of someone who says, "I don't wanna deal with this." Um, or maybe that's not as common as you might think. I don't know, you tell me.
Depends on how you deliver the message.
Mhm.
So coming to somebody and saying, hey, you've got a bunch of denials here. I need you to do this, this, and this. They're going to be like, who's this chick and why is she bothering me? What is going on here? Right? Like, get her to stop.
Yeah,
If I say, hey, and physicians want to perform well by and large. So when in general, when I've said, hey, there's a bunch of denials in this space and in this category, and this is the mechanism, people tune in.
uh-huh,
And you say, I'd like to figure out a way that we can help you mitigate these denials and make it really easy for you to do that and really
uh-huh,
efficient for you to do that. Let me here's a dot phrase that I've started for you. You can edit this at your leisure, but we can incorporate this into your note. I want to think about how it is that I can help you perform better in this space, but I want to make it really easy for you because I don't want you to have to click not one more click if I can help it.
right,
And I'd like
right,
to try to save you some clicks if I can. So let's look
right.
at how you're doing stuff and figure out if we've got any opportunities to save you some effort. That generally is very well received. And I am very grateful to say that I've not had a physician be like, get away from me.
That's good. Yeah,
I but again, I think that it's partly because I'm so laser focused on being helpful to my colleagues and to be of service to my clinicians. By and large, they get it. They're like, "Oh man, thanks." And then they
yeah,
call me for other stuff because once you realize that somebody is trying to help you without making you do more work, that person becomes your friend. So that's been my experience, and I'm really grateful to my Emory community and my colleagues for receiving my efforts in that way. That this is work that I was doing without a title for a really long time. And it was actually the C-suite and it was my boss, Alistair Erskine, who saw me doing what I
yeah.
was doing and was like, this is a really big job and you should get a like this is a job. You should and I feel like it was, part of a plan that's bigger than me. I feel really blessed and really fortunate that it all kind of happened that way. And it seemed like it was supposed to happen because things fell into place. And I can't tell you, I would not have predicted that it was going to turn out this way, not one day before it all worked out this way. Um,
Yeah.
but even before I had the very fancy sounding title that Alistair was generous enough to give me, I had a lot of C-suite support. And in fact, when I was out taking care of my family and I started showing up to these revenue cycle meetings and I started interpreting the clinical documentation for the team, we were looking specifically at our pre-cert process and our authorization denials. And we were looking at situations where the CPT code that we pre-certed was different than the CPT code that we put on the claim. And everybody that wasn't clinical was assuming that that must have been an intraoperative change because there was a change in the codes. And I started reading that last clinic note and looking at that plan of care and saying, hold on a second, folks, because this is what they said they were going to do. And those aren't the same codes that we pre-certed. So there's a
Mm.
disconnect in this process
Mhm.
somewhere else because it
Uh-huh.
wasn't that they changed their plan in the operating room, because what it says in their clinic note that they were going to do is exactly what their op note says they did. And yet
Mhm.
we got this code disconnect. So what gives? I started having that kind of conversation, and finance offered to buy part of my FTE because they found it so valuable to have a clinical partner that was able to translate the clinical documentation into the codes that would help us figure out, did we do what we planned to do?
Mhm.
And if we did, then did we tell the payer that this is what we were do? And if we didn't, then why? And how do we make it really easy for all that stuff to line up going forward?
Well, this is awesome. I'm gonna ask you one more question because I've taken all the time I told you I was gonna take. So my question is this: obviously, you're a surgeon, um, but it doesn't sound like before you got interested in this, you had a big background in finance or that kind of a thing. So you're a surgeon. For other organizations, let's say they listen to this, they've heard about what you're doing, and they say, you know what, we could really use that. You know, that would make a lot of sense. What would be some of the characteristics that you would say, here's what you want to look for someone in this position? I would assume there's some things that you want them to have, and some things that they could acquire or knowledge they could acquire if it doesn't take too long. What are your thoughts there on identifying a good candidate for your role?
That's a great question. I would say I think somebody who can relate well to others and who's uh, mature enough to understand when it's appropriate to check your ego and to be humble. So somebody who can lean into humility as a sign of strength, I think is a personality attribute that I strive for, and that I would say has served me well in the occasions that I've achieved it. Um, you definitely need somebody who understands the clinical terminology. I think that an understanding of the revenue cycle is something that can be acquired,
Mhm.
if not necessarily something that, most of us already have when we come to this, to being at whatever point we are in our careers. I also think that somebody with a desire to serve and who is able to connect to the privilege of service, because there is tremendous privilege in being the person that empties the bedpan or cleans the patient up or brings a glass of water and a blanket. I think that service, there's nothing that in terms of service that I would consider beneath me, because when I serve others, that's a huge high that my brain will deliver. So you want somebody who can really connect to that joy of serving others. And I think a lot of physicians have it, but that's really what makes it fun and pleasurable and satisfying, to meet someone at a time that's convenient to them and be of service to them, and to just help that person have a better day in any way, shape, or form. You don't necessarily, you got to be able to find satisfaction in what it is that you do, because life is far too short to waste time doing things that don't contribute to our existential satisfaction. So if this isn't the type of thing that fills your cup, and if you're the kind of person that needs to be in the operating room doing the surgery to feel existentially satisfied, good on you. God bless you. We need you. But in order to do this work, I think you really want somebody who can find that kind of satisfaction in lots of different types of service. So
Mhm.
you don't
Mhm.
just shrivel up and die if you leave the operating room.
Well, I'm glad you didn't shrivel up and die when you left the operating room, and I'm sure they let you say hi to that crew every once in a while.
It is one of
Um,
the joys in my life.
that's great. Dr. Hack, this has been amazing. I want to thank you so much for your time today, and I hope we can reach out to you down the road.
Don't lose my number. I'm
I
here
won't.
here to help. Thank you,
Have a
and
wonderful day. Thank you.
thank you. You do the same.